afternoon everyone, this is Chaitanya and Roshni, speech language pathologist and audiologist from Pinnacle Blooms Network, Suchitra. Today we are going to talk about the therapeutical management of speech language and feeding issue in children with cleft lip and palate. Before moving into the management of the cleft lip and palate, let us talk about what is cleft lip and palate. Cleft is something, if there is any abnormal fusion or there is any abnormal fusion in the anatomical structure, we call it cleft. So when this happens to the particular structures like lip and palate, we call it cleft lip, and when there is a lack of fusion of palate, we call it cleft palate. Depending on the length and width of the cleft, we have different classifications, and it can be either on the lip or on the palate or on the both sides. And mostly the cleft lip and palate is a congenital condition. And here it's like it's not acquired after the birth of the child. The child will be having the cleft lip during the birth. And there are many factors that is causing the cleft lip and palate. It includes both intrauterine and extrauterine factors. And the factors like smoking, alcohol consumption, drug consumption during pregnancies are the reasons for the cleft lip and palate. And there are also conditions like viral infections during the pregnancies and any kind of perinatal infections during the pregnancies are the reason for the cleft lip and palate. And if there is any lack of overconsumption of medications during the pregnancy time can also be the reason for the cleft lip and palate. And this cleft lip and palate is more of having cosmetic concern. For example, if the cleft is at the level of the lip, there will be more of cosmetic concern than the cleft is at the level of the palate. If the cleft is at the level of the palate, there will be a lot of functional abnormalities seen in the child or the individuals having cleft lip and palate. So mostly they will have problem with the speech, hearing, aesthetics and cosmetics. And when we talk about the incidence and prevalence of the cleft lip and palate, so mainly more males are affected than the female. For say we can say twice males are affected than the females with the cleft lip and palate. And when we talk about the individuals per se, if there are 1,000 individuals, 1 to 2 individuals in 1,000 are likely to get affected with the cleft lip and palate. Next, when we talk about the types of cleft lip and palate, there are different types, and I already said depends on the width and the length of the cleft lip and palate. There are different types of cleft lip and palate. So the cleft lip, it can either be bilateral or unilateral cleft lip and palate. In bilateral cleft lip and palate, both sides of the structure will be affected. In unilateral cleft lip and palate, there will be only one side of the structure will be affected. It can be either bilateral lip cleft palate or bilateral cleft lip or bilateral cleft palate or cleft lip and palate or along with the submucosal cleft lip and palate. Okay, so when we talk about the associated conditions with the cleft lip and palate, when we discuss about the associated conditions that is occurring with the cleft lip and palate, and then only we can talk about the management. So the main concern will be like language delay can be seen. So the children who are affected with the cleft lip and palate can have the language delay. Most of the time they acquire language late, so there can be the problem in the components like semantics, syntactics, pragmatics, morphology and phonology. So and other concerns like speech problems can also be seen, mainly the phonological problems like the poor voice quality like hoarseness, breathiness and change in pitches can be seen. And again another associated problem is the resonance. Resonance will be affected, like we can see the hypernasality, denasality and nasal hair emissions. So in hypernasality, it will be like more of oral sounds will be more of nasalized, and in denasality, nose will be fully blocked, and in the nasal air emission, there will be silent or audible or turbulent flow of air through the nose, which can be seen when they are producing any kind of oral sounds. Next, when we talk about the articulation, you can see more of distortion errors and omission errors and substitution errors. And then then we are going to talk about the speech rate. The speech rate will be slow as compared to the individuals, normal individuals. So, and then when we say feeding issues, so feeding issues will be like more of when it is affected at the level of lip, it will be like there will not be proper seal created by the child to produce or suck the milk out. So there will be feeding issues because of the poor breath pressure. And if it is at the cleft is at the level of soft palate, also the same conditions can be seen, like they will not be able to produce a proper seal, and the proper pressure will not be there. If proper pressure will not be there, there will be feeding issues. And then if the cleft is with cleft lip, soft palate and the hard palate, same problem can be seen because there is no gap between the nose and the mouth. There will not be proper pressure and there will be feeding issues. And apart from all these things, there can also be dental anomalies. So dental anomalies, as in what all dental anomalies we can see is that malocclusions like cross-bite, overcrowding, open bite, and then like dental occlusions will be fully affected. And apart from all these things, we can also see psychological problems in individuals or children who is affected with the cleft lip and palate. This can be mainly due to the cosmetic appeal. Their face might not look good after, before surgery or after surgery, or they might having some kind of like criticism or any kind of from the societies. So these are the conditions that we see in the person whoever is having the cleft lip and palate. So when now it's a main topic that we are going to talk is that like management of the cleft lip and palate. So while treating a cleft lip and palate, we have a team there who are going to work coordinately to bring a good result out of them. So this team includes a orthodontist, prosthodontist, oromaxillofacial surgeons, speech language pathologists, audiologists, occupational therapists, otorhinolaryngologists, and pediatric dietitians. So here a speech language pathologist will be working closely with the dentist to bring a good result out of them. And when we talk about the speech language pathologist, main role of the speech language pathologist will be having a good functional development from the child. And because after repairing the velopharyngeal insufficiency and the anomalies and all, the speech language pathologist will be mainly working on the function of the velopharyngeal port. So when we talk about the speech management particularly, we have prosthodontic management in speech. So in prosthodontic management, prosthetic management, we will be mainly giving the individuals or the kids who are affected with the cleft lip and palate with the speech appliances. These speech appliances will be prescribed after the assessment of the individuals. Like we will have 3 different types of speech appliances depending on the structural anomaly. It's like palatal obturator. For example, the palatal obturator is something which is going to get fixed on the opening of the hard palate. It is going to help the kid to produce a proper pressure, to produce speech sound, and also to avoid the nasal regurgitation. Nasal regurgitation is something that whenever we consume something, because of the opening there can be the exertion of the food through the nose. This we call it a nasal regurgitation. So a palatal obturator is going to mainly help with the speech and the swallowing. Next is a palatal lift. So the palatal lift is mainly going to help with the lifting of the velum to the posterior velopharyngeal wall. It means that whenever there is a production of nasal sounds, the palatal lift will help the velum to rise towards the posterior velopharyngeal port and help to produce the nasalized sound, and it also helps in the feeding. Next is the speech bulb obturator. In the speech bulb obturator, we'll be talking about mainly with the velopharyngeal insufficiency. In velopharyngeal insufficiency, there will be short velum which is not going to sufficiently close the velopharyngeal port whenever there is a production of a oral on the nasalized sound. So this speech bulb is going to rest against the wall and help the port to close whenever there is a need of velopharyngeal sounds. So this 3 speech appliances are mainly going to help with the production of speech sounds and the swallowing of the individuals. So next, the major principles that we all have to keep while dealing with a patient or the individual who is having the cleft lip and palate is that, like, first thing what we all have to keep in mind is that after surgery we will be working with the velopharyngeal insufficiency. Like, there will structurally the things will be normal, everything will be corrected, but still we can see the individuals having the compensatory articulation nasal emissions. Okay, since the compensatory articulations are acquired and there is like they are doing it with their habit, we have to correct it. As a speech language pathologist, we have to see the compensatory articulation and correct all the articulation errors they are producing. And mainly, we are not going to provide any kind of blowing, sucking or any kind of oromotor exercises to the individuals who are affected with the cleft lip and palate, because this condition is not because of the muscle weakness, but this condition is because of the structural weakness, structural issues, structural abnormalities. So any kind of exercises are not going to provide any kind of improvement to the individuals. Next set, we will be talking about the oral placement. The oral placement is like we are going to teach their articulation errors, correct their articulation errors using the oral placement, and this oral placement is of course going to help them to build a proper oral pressure. So, and we already said that we have to work on the hypernasality and nasal air emission because of the kid already had the velopharyngeal insufficiency. So we have to focus on the hypernasality, reducing the nasal emission also. And mainly we will be working on the misarticulation errors also. Misarticulation errors that we can mainly see in the glottal stops, plosives, etc. And when we talk about the uncorrected, if the velopharyngeal insufficiency is not corrected and if it is planned in the near future, we have to work on the oral placements. Even though they are not going to produce a proper air pressure, oral air pressure, we are going to work with the articulation placements, and it may or may not be have much impact, but still we can work on the articulation errors. Next will be motor learning, and we know that we are going to teach them something, and the motor learning is going to come through the practice and through the learning and through the memory. So we all have to keep them practicing. The individual or the child who is affected with the cleft lip and palate is going to practice it every time, it's every now and then, after the session, before the session. And nose plug should be used during the session and even after the session. If the kid is at a session, kid is practicing at home or playing or going to school, a kid has to mainly use a nose plug. Okay, next is that uncorrected velopharyngeal port we already said, and mainly we will be using auditory stimulation and the imitation. It's mainly we have to give them a lot of auditory stimulation and the kid has to imitate the syllables whatever is going to be produced. So in this one, what we are going to use is that repetitive sounds will be used in the form of syllables. It's we will be using it as combined with vowel. We will be using it pa, pa, pa. It's a syllable, it's a consonant that is mixed with a vowel. It's a syllable, we will be saying it as pa, pa, pa is an example, or p, p, p. And this has three groups in it. And this one group, the first group will be having pa, ta, ka, and this pa, ta, ka you are going to combine it with the vowel. And another second group is ba, da, ka, and the third group is ta, sa, sha, cha, and ja. So this sounds you are going to mainly convert it, mainly teach them and correct their compensatory articulation using vowels. And next is we will be mainly using a listening tube. So this listening tube is mainly used to give a auditory stimulation or auditory feedback to the individuals who is having this cleft lip and palate issues. So here is that they are going to correct their errors or hypernasality errors using the listening tube. They are going to directly listen to their voice and then correct it. So what is going to happen here is that this tube, it's one end of the tube will be kept at the floor of the nasal cavity and other end to the floor of the ear. So whenever the kid is going to produce a sound, that if it is nasalized, the kid is going to hear sound loudly. So nasalized sound will be more to the ear. So feedback, auditory feedback can be given to the individuals, and then they can try to reduce their hypernasality. And in conditions of producing oral sounds, though it will be like mainly, they can keep the one end at the oral cavity and other end at the ear. So here whenever they are producing an oral sound, they can mainly try to produce it more loudly and create more oral pressures. So next will be like more helpful will be like oral nasal listening tube. So oral nasals are there. So here it is more efficient than a listening tube. So here what will happen is that the therapist, the speech language pathologist will also have a listening tube with them, and the kid who is going to produce a targeted sound will also have the listening tube with them. So here mainly what is going to happen is that they both will be hearing the sound produced by the kid at the same time and the same volume. So there will be of more auditory feedback, and the individual can correct it. In case of like not available, these instruments or any kind of this are not available, one can even use a bent straw to stimulate the individuals. So next is like targeting the therapy, like targeting the sounds. Okay, so we know that they are going to make a lot of compensatory, obligatory and misarticulation errors. So we should mainly focus on the abnormal sounds and the targeted sounds. So one should take all the sounds, abnormal sounds produced by the individuals, and also the targeted sound, what they need to produce instead of the abnormal sounds will be taken. A list of these sounds will be taken, and the therapy will be scheduled according to that. So what happens here is that mainly the abnormal sounds will be corrected using cues like tactile, visual and auditory feedback. That can be mainly that we can use a listening tube to correct all these things. So what happens here is that, here the targeted sound list will be taken. Either you can use a minimal pair approach or the maximal pair approach to correct the abnormal structures. For example, if you're going to work with the glottal sounds, so we already said there can be a compensatory errors with the glottal sounds, nasal sounds and the plosives. Mainly we will be talking about these three sounds here. So here in the glottal sounds, what happens is that there will be grunt sound that is coming from the vocal cords. So the kid will be asked to keep their hand on the neck and feel the jerk whenever they are producing it. That we call it tactile sensation. So whenever the kid has to produce p, something like that, this thing is going to be combined with the glottal sound like ha. Like the kid will be producing it as p combined with ha, p combined with he. Like that it goes. So like that we can modify this to make them produce glottal sounds. And next we will talking about the nasal sounds like no. So nasal sounds mainly they will be already like water sounds, they are misarticulating. We have to see that. So mainly a sound will be combined with ma sound and e sound, and the kid has to we have to make syllables out of it and they have to correct. And when we talk about the plosives like ka, ga, we have to start with the sounds like nga. So these all things will be done with the feedback, auditory feedback. We can use a listening tube along with all these things. So, and I think we are clear with the management of the speech problems. Now let us move on to the management of the feeding. So we all said that I said that it is very difficult for the individuals who's affected with feeding. Mainly kids are affected having feeding issues. If they are not going to be fed properly, they will have other malnutrition things. So we have lot of techniques and these steps to clear to deal with the feeding issues. First is like a positioning. So whenever we are gonna feed a child who's having this cleft lip and palate, the kid should be in the upright position 60 degree. So upright position 60 degree, they will be like their arms will be flexed and their trunk will be in the midline, chins will be tucked in, and other kids should not be in the horizontal position. This is how they are going to feed the child. Here the nipple will be placed under the roof of the palate. It's like at the base of the palate. This is going to help them to build a proper pressure, to build a compression and suck the milk out. This is how they are going to do the positioning. Next will be the pacing technique. In the pacing technique, we will be going in rhythm with the movement of the baby. It's like infants. We have to look into their reactions whenever we are feeding something, whenever we are feeding them using a bottle or something. We have to see how their reactions are, how their body movements are. So the pacing of the liquid, whatever we are going to feed them, pacing should be given in that proper rhythm. That is, like, the rhythm should be in line with the kids' reactions. Next is like keeping their mouth and nose clean. It's very important. Like, this can cause any kind of infections. And next will be like, next is like using a acrylic feeding obturator. So in this feeding obturator, we have the acrylic appliance kept at the opening of the palate, which is going to reduce the nasal regurgitation of the individual. And this is also going to help the tongue to produce a proper pressure, and then create a pressure and proper seal, and then take the milk. Next is like feeding schedule. How are you going to schedule the feeding? It's like we cannot feed them at whenever we want. It's not going to happen. So whenever the kid is under the age of 3 months or something, there is a need of feeding them for every 2 to 3 hours. It is very important to feed them in every 2 to 3 hours in a normal pace and the positioning. And this feeding time should be extended to 30 minutes. And that's how the kid is going to be fed. And frequent burping of the kid is also very important. As we all know, then the kid is affected with the cleft lip and palate. When feeding, the mouth will be open. They are going to intake lot of air through their mouth. So what will happen? There can be issues with burping. So what they will do is that we have to make them burp every now and then. In every 15 minutes, we are going to make them burp. And next is like we are going to make the child sit in the upright position. Every time the kid should be in the upright position, not like in the horizontal position whenever we are feeding. And next is the use of proper nipples or the bottles. I'm not going to into the much detail on the name of the bottles and nipples, but there are many nipples that is going to facilitate the feeding in the individual. And this feeding bottles will be prescribed by the feeding team. So we have a team there. So there will be nutritionist, lactation specialist will be there, and with the concern of occupational therapists and the speech language pathologist, the feeding bottle should be prescribed to the kid. So the feeding bottle, as in we can see pigeon nipple and like Hedgehogson, like cleft palate nurses, and this kind of bottle and nipples can be prescribed to the individual. And this is all about the management of speech and speech language and the feeding. If you have any questions, we can ask.